Hello everyone, and thank you very much for joining us today. My name's Deborah Garlick from Henpicked and Henpicked Menopause in the Workplace, and today's theme of the Lunch and Learn is your HRT questions answered. And thank you for submitting so many questions. I have to say we've been absolutely inundated, and there are some really strong themes throughout the session today. So we're going to try and answer as many of those questions as we possibly can. And we're going to look back on all of the questions we've had. So I know that I've already been in touch with some of you to say, actually, have you looked at this resource? So it may feel a little bit like the John Craven's news round of questions. So I'm delighted that we have back with us Dr. Heather Currie, MBE, who is the founder of Menopause Matters, amongst so many other things. Heather, last time we did this Lunch and Learn together, we could have been on doing the session for a couple of hours. And so today we invited you back to answer some of those questions and some of the questions that we received over the last couple of weeks, to answer as many as they come, as many as we can. So thank you very much for joining us. And I might jump straight in by saying some of the key themes are around, and we have got a list and lots of pages, when you can take HRT, how menopause is diagnosed, the symptoms around menopause, and does HRT help with those, some of the side effects, how you take HRT. We've had some questions on cancer and HRT and talking to your GP and at work. So I'm going to jump straight in with the question around when can you take HRT? The first one is, and just to make sure everybody's aware, I will not use any of your names during this webinar. We will keep these questions anonymous. And also, unfortunately, we can't give individual advice during this session, but we will make sure that we're giving lots of information and signposting during this time. That's okay, Heather. Thank you for joining us. It's I know you're very busy, so really appreciate your time.
You're very welcome, and thank you for having the opportunity, because we did run out of time the last time. So the first question, when to start HRT? So let's go back to basics. There are three indications for taking HRT. One is for treatment of troublesome menopausal symptoms, for which it is the most effective treatment. Two is for treatment for following premature ovarian insufficiency or early menopause, when most women in that situation will have menopausal symptoms, so they'd be taking it for symptoms. But even in women who are not having symptoms, who are very young at the time of menopause, it is recommended that they take hormonal therapy at least until the average age of the menopause, because it not only controls symptoms, but reduces their risks of bone problems, osteoporosis, and also cardiovascular disease. And so in those women, it's replacing what usually would be there anyway. And the third indication is for treatment or prevention of osteoporosis in women who have particular risk factors and under the age of 60. So, for example, a strong family history. So the main indication of all of those, the most commonly used one, is for treatment of troublesome menopausal symptoms. So when would that be? So the age varies. So for women who are still having some periods, but starting to have a change in the pattern and starting to experience some of the symptoms, that can be in the 40s, mid 40s, even early 40s. And that's that stage of perimenopause. So it can be considered then. However, if you have absolutely completely regular periods, then it may be that the symptoms you're experiencing are not hormonally related, because normally, along with the menopausal symptoms due to us becoming lower in estrogen, there is a change in the period pattern as well. At the other end of the spectrum, at an older age, some women are now thinking, well, I actually didn't have too much trouble at the menopause. I'm now in my mid to late 50s or early 60s. Should I be thinking about HRT for other benefits? And really the answer is no. So we're not using it for prevention of long-term disease in women who are not having menopausal symptoms. There is not enough evidence to say it should be started at that stage. And there are potential extra risks of starting it a number of years after your periods have stopped if you've not had HRT in between. And while we do need to be aware of long-term risks, long-term consequences of our ovaries stopping working and becoming low in estrogen, such as our bone health and heart health, there's lots and lots of stuff we can do to look after our bones and our hearts, such as healthy eating, plenty of exercise, not smoking, minimizing alcohol and caffeine. All that kind of general information is probably more important, or at least as important, as the idea of starting HRT at a later stage.
Wonderful. Thank you very much, Heather. So I'll just recap on this because I'm crossing these questions off as they come along. So if somebody believes they're in perimenopause and mood is low, experiencing symptoms around psychological symptoms around mood and irritability, periods have now become irregular, but tests are saying they are not in the perimenopause. Now, this one's quite interesting because tests are saying not perimenopause, but symptoms are showing. And this comes down to testing, doesn't it?
Good. Someone's answered the phone. That's good. So it depends on the stage you're at. Blood tests in women 45 and over are not recommended to either diagnose perimenopause or menopause. More important is to go by what symptoms you're having and also if there is a change in your period. So if periods mentioned are irregular, if the common effect is that they start to spread out a bit, and if that's linked in with starting to have the menopausal symptoms, and I think we talked last time about what they are, classically flushes and sweats, but low mood, anxiety, irritability can be all part of that as well. So with a change in period pattern and symptoms such as those, if you're 45 and over, there's actually no need to rely on a blood test because the blood tests go up and down like a yo-yo. Some even 40 to 45, they're not always helpful. So sometimes more important with that, you can make the diagnosis without the blood test. And therefore, it may be reasonable to have a trial of HRT. And often that's the best way to know, is this what you're needing? Is this what's going to be helping? And at that stage, you would always start with a low dose because you're still producing some hormones or else you wouldn't be having periods at all. And the idea is just to top up the estrogen levels at that stage, which a 3-month trial will give you a good idea as to whether it's helpful or not.
Wonderful, which brings me on to one of the other questions, because you've explained about blood tests not necessarily being the way to diagnose. But in terms of the right level of HRT, I've got one that says blood test with a menopause practitioner to determine the right level of HRT for me. So if the regimen is to start lower, it's not a blood test to determine should you increase it or should you increase it. It's more about the trial and error of saying, or the trials of saying, actually get it up to a point where it's best for you.
So the best way of testing what's best for you is going by how you feel. There is tending to be a focus on measuring blood tests and increasing estrogen levels to get it to a certain level, but actually that is rarely helpful and rarely needed. And what is most important is to start with a reasonable dose, which means actually starting with a low dose in most women. The only situation when we would tend to start with even a medium dose, but I can't see any situation where you should start with a high dose, is the medium dose you might go with if someone's had an induced menopause, which means if they've had a sudden menopause brought on by treatment or brought on by surgery in younger women who had completely normal ovarian function before that event, because they have a sudden drop in the estrogen. So to replace that with a very small dose would be unlikely to be helpful. So in that situation, you'd start with a medium dose. Generally, though, you're starting with a low dose because often that's all that's needed. And in any therapeutic area, there's no need to give more than you need. So then you go by how I feel. And there was a question, I think, around how long do you know? How long do you give each type before you know whether another change is needed? And it should be ideally at least 3 months, because it can take that long, A, to have the full benefit from what you're taking, and B, to have side effects which may happen initially, but then they often settle. So there would rarely be a situation where you would change the regime or the dose after a few weeks. So ideally give 3 months to see what the effect is. And that is why if someone's starting HRT or starting a new regime, we recommend a review mostly within primary care after 3 months. And it can be a telephone review just to see how you're feeling and what's going on. And so from there on, it continues to be how you feel. So some women might be okay on a low dose, but a few months later or a few years later, as the own ovarian function is producing even less, then they may need to chop up the level a little bit more. If you're taking tablet form of HRT, there's never any point in doing blood tests because the estrogen we swallow is converted into other things that we don't measure. Sometimes it may be helpful if you're using a patch or a gel to check the absorption. That would only be if you've needed to go up to a sort of highish dose, but you still don't feel it's controlling symptoms. We're all different. Some women absorb really well through the skin, whether it's a patch or a gel. Some women absorb better one from the other, and some women rarely don't absorb at all, and they're better if they can by taking it by mouth. So sometimes when you're wanting to know, this is a high dose patch, is this really now working? And that's when a blood test may occasionally be helpful, but we shouldn't use that as the routine. We shouldn't be relying on blood tests to know. Much more important is how you feel. And you know what comes over and over is individualization. We're all different, so any advice that we give might be appropriate for one person but not for someone else.
Thank you very much, Heather. Just a quick one on this one, because I think you covered it, but people wanting to start HRT, i.e. I've got a question that says, I'm 56 now, and finally through the end of my symptoms, but they're getting less intense. I haven't taken HRT and have battled through. However, I'm now wondering if it was a mistake not to take HRT. As you've seen reports that HRT can help with dementia and osteoporosis. Is it too late to take HRT? When is there ever a time that it's too late to take HRT?
So yes, if the symptoms are now reducing, then we're not in a situation for taking it purely for a preventive reason. For osteoporosis, we know osteoporosis is really common, but then again, it would be individualized. So for example, if mom had osteoporosis, if you've had a parent who's had an osteoporotic fracture, that does increase your individual risk. And there are discussions around bone health. There's a tool that can be used online called FRAX, which can give you information about your risk of having a fracture, taking into account your medical history, your family history. And if it does look like you're at an increased risk of osteoporosis, even if your symptoms are reducing, then it's reasonable to take it for that reason. There is a lot of interest now in dementia, and the evidence is just not strong enough to suggest that HRT should be taken purely for prevention of dementia. It's not strong to recommend it for that reason. If you're taking it for symptom control, then it may, and it's a may, give that extra benefit. If we look at, we mentioned, you know, is it too late? So women in their 60s, for example, who've never taken HRT, to start it after a gap may actually increase your risk of dementia, for example. It would still be helpful for bone health. We know if HRT started early, it's very helpful also for cardiovascular health, for your heart health, but not if you start it later. It doesn't do any harm, but there's this kind of window of opportunity where for those later effects, cardiovascular disease, query dementia, it needs to be started within 10 years of the menopause or under the age of 60. But generally is only needed then if you're using it for symptom control, not purely for the preventative measures.
It would be lovely, wouldn't it? It would be amazing if they did that research and found that actually HRT does help in that sort of way. But as you say, the research isn't finalised yet.
But the other point is, you know, rather than the focus being so much on HRT, yes, it's fantastic for many women. It can be life-changing. It can be really helpful when used appropriately. But there's other things we can all do. So the message now related to brain health is around we should look after our brains the way we look after our hearts. So the same healthy lifestyle, plenty of exercise advice also applies to our brain health. So, you know, we shouldn't think that we've missed out. There's other stuff that we can do to look after our later health.
Thank you very much, Heather. And you mentioned about HRT for its benefits in managing symptoms. And of course, we've had a lot of questions around it in terms of Increasing HRT would be the headline, I would say, for this question, to help sleep. Link with memory loss and menopause. Can HRT improve memory? Anxiety. So some significant requests, but it was interesting. A lot of them were around the psychological symptoms. I think the message is through there that HRT is a good way of managing hot flushes and more of the physical symptoms, but these were predominantly around the psychological symptoms, the ones that many people may start to experience and not even put it down to their menopause transition. So is HRT a good way of managing those symptoms too?
So yes, it can be. And the focus in the past has been on the main symptoms being flushes and sweats. And I have been aware of women who've had the other symptoms, of which there is more awareness now that it can be hormonal related, as you've described, Deborah, but sometimes been told, well, you can't have HRT because you're not having flushes and sweats. But actually, the lack of estrogen can affect you in that way. Having said that, though, if you have taken a reasonable dose, so it started with a low dose, crept up to a medium dose of HRT, and there's no difference, then it doesn't always help to keep increasing the dose. And we do sometimes see women on really high doses of estrogen. And I want to come on to talk about progestogen. So far, what we've talked about is mainly estrogen, but higher and higher doses don't necessarily always help. And sometimes it's worth just remembering life has been really difficult the last few years. In fact, it's 3 years from around now, isn't it, since we went into the first lockdown? Probably was this week, I think. Or and life has been really difficult, and that can have a huge impact on us, adding to the hormonal changes that we may be experiencing as well. And often women find a lot of benefit from, yes, taking their HRT, but rather than increasing the dose, if they still have some psychological symptoms, to also think, well, what else can I do? And again, lifestyle is really important. Getting outside, exercise is really important for our mental health, not just physical health, but also cognitive behavior therapy has been shown to be really helpful for reducing menopausal symptoms, particularly the psychological changes. And there's a really good fact sheet on Women's Health Concern that you can access that. So there are other things that we can do rather than necessarily increasing the dose of estrogen. But yes, HRT can be started for the psychological symptoms, even if you're not having the flushes and sweats.
Thank you very much. And the one that is quite interesting has come through around the anxiety. And as you say, we're all different. You have to ask yourself, how am I feeling right now? But not necessarily see HRT as the only thing that you can do, or, if you do HRT, everything goes away. One has come in around suggestions with dealing with anxiety. Seems to be a lot worse since menopause. I've tried 3 different antidepressants and anxiety tablets from the doctor, but none have actually worked, and that's in conjunction with HRT. So, is it this sort of combination effect?
Yeah, sometimes the combination can be really helpful, and as you said, it's not always purely relying on HRT. As I've said already, HRT is the most effective treatment for menopausal symptoms, but it can't treat everything. And I think in the past, women have sometimes not benefited from HRT when they could have, because of fear about risks, concerns about using it. But now I think sometimes there's too high expectations of what it can do. It isn't the magic answer. It treats symptoms related to low estrogen, but there's lots of other things in our life can impact on that.
Wonderful. And I'm just going to ask you a question about, you mentioned progesterone there. We're halfway through. So, and I know there's no quick answer to this one. And we are going to be running another webinar on progesterone, to focus on progesterone in view of the questions that we've had actually on themes from other lunch and learns. But, this estrogen and this progesterone as well. That's something. So does that help with symptoms? Is this something you need to know about that?
Yes. So what we've referred to, as I said already, is really around estrogen. So the consequences of menopause, whether it's early symptoms, later health problems, the intermediate stuff affecting vagina and bladder, is all around becoming low on estrogen. So it kind of makes sense that what HRT aims to do is replace the estrogen. And that, as we've mentioned a little bit already, that can be in tablet form, in patch form, in gel form, or in a spray. Or for the vagina and bladder symptoms, it can be a vaginal tablet, cream, pessary, a variation, various things are available. If we just gave estrogen, what we call systemic estrogen, so this isn't relevant to the vaginal estrogen, this is when we swallow a tablet of estrogen or stick a patch on or use gel or spray, eventually it could lead to increased risk of cancer of the lining of the womb. So it can stimulate the lining as it does in our normal cycle. In our normal cycle, it is balanced in the second half of our ovulatory cycle, normal menstrual cycles, by progesterone. And the job of progesterone is to prevent the estrogen continuing to stimulate the lining of the womb and preventing it becoming unhealthy. So with HRT, it's the same. If we give estrogen, we have to balance it with progesterone, or the term for the different types is called progestogen. And so that can be taken also in tablet form and in patch form, or as a separate tablet that's taken on its own along with estrogen. And the progestogen, how we give it and whether or not it will lead to monthly bleeds, is related to where you are when you start HRT. So if you're in perimenopause, so you've still got some menstrual cycle going on, although it's changing, you would, with any type, you would take estrogen every day in one form or another, and you would take progestogen for part of the month, which is kind of mimicking our own natural cycle. That would bring on a monthly bleed in most women. If your own periods have actually stopped, you can take progestogen every day along with the estrogen, and that keeps the lining of the womb thin without recreating a monthly bleed. The concerns that we're seeing in recent times is, I mentioned a little bit about this idea of increasing doses of estrogen, sometimes increasing it too quickly. And sometimes the progestogen then that's taken, particularly if it's taken separately, isn't enough to keep the lining of the womb under control. And we are seeing more people being referred because bleeding problems, and often it is due to this imbalance between the estrogen and the progestogen. So we really have to bear in mind the importance of keeping the balance right. And sometimes as regimes get really complicated, such as so many pumps of gel a day, separate progestogen, it all goes wonky, and it can be dangerous actually, related to the effect on the lining of the womb. So the message is always keep it simple, keep it safe. And so when we're tweaking about with the estrogen, we have to remember the progestogen part is really important. If someone's had the womb removed, a hysterectomy, then they don't need to worry about progestogen, and life is a lot easier.
Wonderful, thank you. That answers that question then. And we, as I say, we are running a webinar on progesterone, so stay tuned for that one. And I would also encourage people to look at the webinar on testosterone, because there was a something came up in chat there that said don't forget testosterone as part of that. So do watch Dr. Tonya Wakoma's previous webinar on testosterone too. But Heather, you just mentioned the delivery method, if you like, and we've had a few questions around which one to take. You know, you've got your patches, you've got your gels, you've got your tablets, you've got your sprays, you've got your implants, you've got different things. So when it comes to the delivery method, there was a couple of questions around which one the GP had recommended, and is it better gel, patch, or tablet? How is that determined?
Yeah, so again, it's individualized. There isn't one that's best. There isn't one that's going to suit everyone. And so it's starting with some basic principles and then tweaking as necessary. And as I mentioned before, any tweaking should be only after at least 3 months of trying any particular type. So I'll do the easy bit first. If the main problem you're having is related to vagina and bladder, you don't need estrogen that goes through your whole body. You can just take vaginal estrogen. That's straightforward, simple. There's lots of options available, and there's one that you can buy over the counter now. If you need it for flushes, sweats, mood changes, psychological changes, joint aches, all those symptoms, you do need something that goes around your body. And actually, for many women, a simple, convenient daily tablet will do that for you. And it can either give you estrogen only, it can give you estrogen with progestogen for part of the month for the perimenopause, or it can give you estrogen and progestogen every day. In the past, we used to use tablets hugely. And actually, if we think back and don't forget some basic principles, a lot of the research which showed benefits of HRT was based on tablet form of HRT. So when I started the clinic in my area 30 years ago, there weren't many patches available, and there certainly wasn't any gel, and there wasn't a spray. That's very recent. And so, you know, the focus was on tablets, and we knew for many women that provided more benefits than risks. In recent times, there has been more of a focus in using what we call transdermal estrogen, so when it goes through the skin. So that can be a patch form, and patches can provide either estrogen on its own or estrogen combined with progestogen, all in the patch. That's fairly straightforward. But a gel and a spray only provide estrogen. So if you are going down that route, then you need to take separate progestogen. And that, to me, just starts complicating things from the very beginning. So the situations when you would think about the transdermal through the skin rather than a simple convenient daily tablet would be if you've had risk factors for a deep vein thrombosis, so DVT. So we know with tablet form of estrogen, one of the concerns is a small increased risk of having a DVT. If your baseline risk is already really low, a small increased risk is still going to be really, really low. And so for many women who've not had a previous problem, who don't have a strong family history, who are not overweight, then their risk of taking tablet form of HRT is minimal. And what we need to remember, I talked about that importance of the progestogen protecting the lining of the womb. You get better effect and less bleeding, i.e. better bleeding control, taking a daily tablet that contains both hormones, rather than when you start separating the two hormones. So another reason to consider taking it through the skin would be if you have a history of migraine, especially if it's migraine around period time, because sometimes it's the time when your hormone levels are fluctuating that can trigger migraine. And with a daily tablet, then you can get a little bit of fluctuation. And there are some other medical conditions such as gallbladder problems or liver problems where you may, or bowel problems. If you're not going to absorb it very well from your bowel, then it's not going to work very well with tablet form. But there are many women who currently are taking complicated regimes that actually would be fine with a daily tablet. When it comes to transdermal, whether it's a patch or a gel, again, it's very individual. The benefit of a patch is you have the option of patches that also provide the progestogen, whereas gel is estrogen only. So it's always going to be complicated if you start with a gel and separate progestogen. And some women absorb really well through the skin from a patch, others absorb better from a gel, others don't absorb very well from either. So, you know, you only know when you give it a trial to know if that one's going to suit you or not. Some people find patches cause skin irritation, others find the gel a bit messy. So there's pros and cons either way. So, you know, the initial message is there isn't one that's best, and it often needs a bit of tweaking to get it right.
So not a superior version, more about us being individual and trying, as you said earlier, starting small and growing to the point where you're at your optimum for you. At that point, you answered a lot of questions there. I was almost playing bingo with all of the questions that are going on, but we are running over time. So if anybody needs to drop off, you can always watch the recording again. And of course, we'll send out the notes if you're okay to continue, because there's a couple of areas. And lovely to see you, Sally. I know you've been busy with the questions in the background, but there was a couple that were very, very specialist. And I think what we need to do is signpost those individuals, and I'll get in touch as well, Sally, to say there is a separate session on cancer and HRT, which was incredible, with Dr. Karen Morton. So do refer to that one, because I think we could probably go on for another hour just on cancer and HRT. But one I do want to two quick ones, if I may.
Yeah, sure.
Is around side effects, because we've got several that are saying they're getting side effects. I swear I didn't write this one, but I could have done. My boob size is increasing. Will it stop when my HRT stops? Excessive bleeding, or starting periods again, which you already covered. and that, but then I'd really like us to discuss a couple of really in-depth, if you've got time, on how to talk to your GP. And actually we've got a really actually I found it quite heartbreaking, where an individual is getting conflicting information from different GPs in the practice, and also from a specialist. So may I just ask you a quick one on side effects? If you're getting side effects.
So side effects are quite common, and as I mentioned, often initially they're more likely if you started on a higher dose than you need, which is where the principle comes from, with starting with a low dose, as opposed to starting, even a medium dose can be too much for some women. And so often you mentioned the breast problems, so breast increasing in size, breast tenderness is really common, bloating, headaches sometimes. And these can be due either to the estrogen or the progesterone. Commonly, the progesterone part is the one that causes side effects, but as I said, estrogen can, if it started in more than you need. They often do settle by the 3 months, so it is worth persevering. For the breast symptoms in particular, adding in starflower oil or evening primrose oil can be really helpful. Wearing a firm supportive bra, cutting down caffeine, fizzy drinks, caffeine can affect sort of breast discomfort. So simple things like that can be helpful. So hope that's okay about side effects. I think you've muted, Deborah.
It is. Thank you very much. The one thing in terms of talking to your GP, now everybody on this session and everybody that comes to our lunch and learns, I think that's remarkable, because one of the things that we say is the thing that you need to do, you mentioned it earlier, understanding what's going on for you. How do you feel right now, and keeping a track of it, your symptoms over time, so you can understand what is actually going on. Understanding menopause, reading up about it, both in terms of the facts, the facts, and also your options of what you can do, so you can go prepared for that conversation and say, this is what I'm experiencing, this is what I've been reading up about, this is what I think I'd like to do, what do you think, based on my medical history, and have that conversation in a different way. And the top tip that seems to work time and time again is, when you make your appointment, do ask who in this practice is the best person to talk to about menopause. You might have to wait a little bit longer. It might be the practice nurse rather than the GP you usually see, but that has huge impact. So do check who in the practice is the best person to talk to. The receptionist will know who has a specialist interest or who has extra training. But the one that worries me more, Heather, is two of the questions that we have is where individuals have been to see their GP, and one in particular had an accident and fractured their shoulder, and has immediately had an operation for pulmonary embolism, and she was being told, yes, you can have HRT, no, you can't have HRT. Conflicting advice from different GPs and specialists.
Yes.
It
is difficult. So as a sort of way of reassurance, in some way, I'm very involved with the British Menopause Society. There is an enormous amount of education going on for all healthcare professionals, not just GPs, but in particular for primary care, GPs, practice nurses, community pharmacists. Each region will have, in Scotland now, every health board has a menopause specialist service. It's not quite that good in England, but there are increasing numbers of specialist services, which are also, their job is to support their GP. The primary care teams provide education. There's loads of online resources. So it is really difficult. And sometimes you're left thinking, well, how do I know who to believe if one person is telling me this and that? With that history in particular of, I presume it was related to the immobility around the time of the accident and the surgery, that there was a pulmonary embolus. So while that's active and in the active time of treatment, then it would be appropriate not to take HRT. But if you do have troublesome menopausal symptoms, having stopped the HRT, it can be considered to take it transdermal. So the tablet form can further increase risk of pulmonary embolus or DVT. So that absolutely wouldn't be recommended, but the transdermal form can be considered. And I think part of that problem is that not all healthcare specialists understand the differences between the different types of HRT and haven't necessarily kept up to date with the research, which is understandable. They can't be experts in everything, but that's where the local menopause specialist services come in. So on the British Menopause Society, there is a link to show where there are BMS recognised menopause specialist services around the country. It's very likely the one will be one near you, and you can ask to be referred if you're not sure about the advice you're getting or you're getting conflicting advice. You can ask to be referred, and a referral wouldn't necessarily mean you having to go there. It can be email advice through referral systems. We can give back advice. And so it may be just that backup that the primary care team need.
That's wonderful. So if you're finding yourself stuck in that sort of way, ask for a referral or ask for a recommendation. Or can you ask a specialist that is actually an expert in this, rather than just thinking, because, you know, it must be so confusing. It's a horrible situation to be in. But there is extra help out there. Thank you very much, Heather. So I'm afraid we've run out of time again, and I've got to say thank you very much again, Dr. Heather Currie, and thank you for all of your questions. I know Sally's been in the background answering as many as she can too, and also signposting to extra resources, but do also check out Menopause Matters. I know Sally's put a link in the chat so everybody can go through there. There is a wealth of information on Menopause Matters website and lots of fact sheets that you can download, and, you know, avoid reading the myths and go straight to the facts. Or alternatively, I think you can register for your magazine online, because I can never get it at WH Smith's. Got to say, Heather, I think everybody beats me there. So you can register for that one too. And you can look on henpick.net. I know in a lot of the chat there were questions around what do you do about this. There's over 50 of these types of webinars in there on lots and lots of subjects, whether that is testosterone, libido, anxiety. So do check that out too. Thank you for joining us, and thanks again, Dr. Heather Currie, and to Sally in the background for managing all of the questions, and we look forward to seeing you again soon. Thank you.